So as I said earlier, I now serve as the director of the BIDMC Lymphatic Center. And over the next 45 minutes, what I'd like to do is we're going to be giving this talk. I'm going to give it with my colleagues, Ms. Kathy Shillue, who's the director of outpatient rehab services at BI and the director of our lymphatic treatment clinic. Can you wave, Kathy? Thanks. Dr. Carroll, who runs, he's the director of vascular medicine and runs our lymphatic medicine clinic. And Dr. Tsai, who's head of our director of oncology imaging, and he runs all of our lymphatic imaging. And together, we're going to give you an overview of the BIDMC Lymphatic Center. So, I was thinking before we dive into the nitty-gritty, I just want to give you some quick facts about this center. Dr. Carroll actually told me to spice it up a little. So, I don't know if this is spicing it up enough, but I think some of this is good. So it was established in 2016. So we are 3 years old, essentially, next month. We truly are patient-oriented and multidisciplinary. I think the multidisciplinary you'll get going through the presentation. Patient-directed, I've seen a lot of patients that come to see me. You can talk to patients that have come to see us. We are very goal-oriented. There is no cure for lymphedema. We recognize that. We don't have a cure, but we have things that can improve your quality of life in various ways. But we got to know how you want your quality of life improved. So we are very much goal-oriented and patient-oriented in the evaluation. This number blew me away. I asked our database people to go back and look at our database. Since we opened our doors 3 years ago, we have seen 718 new patients for lymphedema or lymphedema prevention. That's in 3 years. And a big key to all of this is the final thing. It's institutional support. 6 weeks ago, Brett, Leo, Kathy, and I sat in front of Pete Healy and Sam Skura, president of BIDMC and vice president of BIDMC. We showed what we were contributing to the field and to patients in the region. And I can tell you now, they have put forward multi-million dollars earmarked for lymphatic care over the next 5 years. Not only have they said they're going to do it, we have all already seen some of the things we're requesting coming through. So much more to come, and let's keep pushing this forward, and thanks to the likes of Dr. Slavin for slicking the slide for us years ago. All right, as an outline, we're going to give a little background about lymphedema. We're going to talk about our clinical program. Depending on time, I'll touch upon our research program, and we'll make a concluding remark. Now, why do we have a lymphatic system? So the lymphatic system helps us fight infection. It helps with fluid balance in the body. And it's actually really important for lipid absorption of the gut. Okay, it's one I often actually don't mention, and Dr. Padero, one of our collaborators over at MGH, I said, no, Dhruv, that's a key third factor. And so appropriately, I'm putting it up there. And if I try to talk to you about what is lymphedema, and I explain that there's an arterial supply, a bunch of blood leaving the heart, it's all got to go back to the heart via the veins and the lymphatic system, 90% via the lymphatic system, 90% via the venous system, 10% via the lymphatic system, you'll all fall asleep pretty quickly. Now, if you've been to our clinic, you know this analogy. So just bear with me. If you haven't, this will be new to you. So what I like to talk about is what my 5-year-old and 2-year-old like to talk about, and that's trains, okay? And this is how we talk about lymphedema really throughout the center. And what we say is, look, the heart is the biggest train station in the world. And every morning, a big red train leaves that station. It's chock full of passengers, and every passenger has a seat. Now, let's focus on a patient here that might come in with left upper extremity lymphedema. So that's on that side. So the red train, dedicated to the left upper extremity, takes off in the morning, makes its way down the track. By the time it hits the tips of the fingers, all the passengers have come off the train. Okay, they've been dropped off along the way. Well, 5 o'clock whistle hits, and everyone wants to go home. 2 trains come home, a blue train and a yellow train. The key concept to understand is both blue and yellow trains need to be working, and they need to be on time for there to be enough seats for those morning passengers to make it home. 5 o'clock whistle hits, blue and yellow start at the end of the line. They make their way back. Everyone's happy. You never even knew you had trains in your body. The analogy here is red trains are arteries, taking blood away from the heart being the main train station. The evening trains, blue are your veins, bringing blood back, and yellow are your lymphatics, bringing some of that fluid and protein back as well. So what I would tell a patient who presents with lymphedema is let's focus in on the yellow train, starting at the end of the line, it's making its way back, and something happens. And we won't talk about what's going on yet, about why that train came off. We'll talk about that later, but that train comes off, and the train comes off the track. And we've all been there, right? We miss a train, plane, we kind of just hunker down and wait for the next one. We usually don't make a fuss. But what if that Delta agent said there's no plane coming? You might do this. You might get really angry and riot. And that's actually what happens in lymphedema. You can start developing lymphedema in a subclinical stage and not even know it. Now, if you had really sophisticated machinery like we have, Cheryl and her team have at MGH, you might be able to pick up on this even before the patient actually has symptoms. And what's actually happening at the cellular level in the actual tissues? Well, lymphatic channels are just like regular arteries and veins. They're tube structures. And what happens is when you have sleeping passengers, the cells along those channels start to swell. Then there's eventually barrier integrity loss, and the lymph flows out of the channels into the interstitial space. Eventually there's inflammation, and that's when the passengers start to riot, and there's begin to be issues. And so there is a staging system for lymphedema. I'm not going to go into it. I think it's very controversial. I personally don't believe professionally believe there's a great staging system yet, but it's important to understand that this is a progressive disease if it is not managed. Most common symptoms are pain, throbbing, tightness, heaviness, and unfortunately, recurrent infections. All right, so we said we weren't going to talk about what caused that train to come off the track, but let's briefly touch upon it. There are two causes of lymphedema, primary and secondary. Primary, going back to the train analogy, is the tracks were never built entirely properly at birth. And that could present at various time points. Dr. McClellan, I'm sure, will talk about that more in his talk later in the symposium. Secondary lymphedema is where the entire train system was there, was working beautifully, but then something happened to it. And because of that, the lymphatic system is now damaged, and that's a secondary cause. The number one cause in the entire world of lymphedema is secondary. It's a filariasis infection. The number one cause in the United States is secondary, but unfortunately it's us, it's surgeons, trying to prevent the spread of cancer, taking out lymph nodes usually, and resulting in lymphedema. All right, so the traditional model, and I'm not going to go into this because Kathy's going to really dive into this later, is manual lymphatic drainage, compression bandages, exercises, and when we look at our train analogy, it's the same as saying, look, we have a yellow train that's not working. Let's hire a bunch of people, put it behind the train, and push it the rest of the way. It'll work. The train will move, but it's not a cure, and it's lifelong. So the question becomes, is there something else we can offer? Now, again, this is a little bit of a busy slide. You might fall asleep. So I'll just say for surgery, we have two kinds of surgery, excisional procedures, physiologic procedures. Excisional, I'll just go back to the train analogy. I'm going to talk more about surgery later, but this is just a brief introduction. Surgery is excisional is where we take those stranded passengers and we just hose them down and get rid of them. We'll talk about that more later. Physiologic is where we actually try to fix the train or the train track. So maybe we bypass the yellow train onto the blue train track system, or we build you a brand new yellow train souped up with a new train station. One thing we are working on, as Dr. Slavin kindly mentioned, is we are working on prevention. And I do believe we have the largest experience in the country right now. And what we do, and this is a panel from a book, Megan Bellinger. Megan, raise your hand. Megan is not only an amazing certified lymphedema therapist, she's an amazing artist. And together we've written a book that we're working with LE&RN, Bill and Michael, to get into a book format. And this is one of the panels where we show, look, if you know you're going to injure the yellow train track, why not just reroute the yellow train onto the blue train track system before you cause the injury? And that's literally what we do in the operating room. All right, so with that, I'm going to dive into our clinical program. And I was told, I think at our last talk at LE, I should stop putting up the slide about teamwork and the Red Sox. Maybe this is not the year. But they have been good. And teamwork is critical. And literally everything we accomplish in our center occurs because of a slew of people working very hard. And you're going to meet them today at various time points, whether they're going to come up here and talk or they're going to be leading some of your small group sessions later. And so when we look at our program, there's really 3 components that I call the clinical triad. And that is lymphatic surgery, lymphatic therapy, lymphatic medicine. And again, we call that the clinical triad. And we are really the front lines. When you call us and you have lymphedema or you want prevention, you're going to see somebody from one of these 3 clinics first. However, we also get heavy support from radiology through nuclear medicine and body imaging. And if I may, I call that our all-star team. And if we get a lot of support from other services along the way as needed. And just to show you what we look like, I am the lymphatic surgeon of the center. I'm heavily supported by Tilly and Sarah. Raise your hands, guys. They are our nurse practitioner, and they are dedicated to the lymphatic clinic. In lymphatic therapy, we have Kathy, Colleen, and Stacy, certified lymphedema therapists. And I know I'll put in a plug, we are expanding our lymphedema therapy team in the coming months. Lymphatic medicine, we have Dr. Carroll. Dr. Carroll is head of lymphatic medicine, and he will be talking shortly. Dr. Tsai does all our body imaging for lymphedema. He'll be talking shortly and explain some of the imaging studies we get and why we get it. And then Dr. Donahoe from nuclear medicine does the lymphoscintigraphy, and Dr. Tsai will be talking about his work as well. This is all of us kind of put together at a 7 a.m. being told to smile. And so this is how our center works. If you call us, you fax us, you send up a bat signal, or if somehow you get to us, that's a referral. We will do a screening of some kind, either by email or by phone call, and we will quickly figure out, do you have lymphedema, and we're trying to treat it, or are we trying to prevent lymphedema, i.e., you have cancer, and you are about to have a cancer operation, and you have been identified as being high risk. Each of these patients are treated differently as they go through the system. A preventative patient is more urgent because they have an active cancer and they need to go to the operating room quickly. So they're seen in my clinic immediately, in our lymphatic surgery clinic. In the lymphedema treatment clinic by Kathy, we quickly coordinate with surgical oncology and we proceed to the operating room. And then all of our patients always enter our surveillance program. On the other hand, if you have chronic lymphedema, your first protocols will actually be with the lymphatic medicine clinic with Dr. Carroll and his team, which is expanding things to support from our hospital, and the lymphedema treatment clinic for measures. From there, we will answer 3 questions. Do you actually have lymphedema? Surprisingly, up to 25% of patients who come to us thinking they have lymphedema do not. We will make sure that conservative therapy is maximized, and we'll make sure you're an appropriate surgical candidate. And after that, you would make it to a lymphatic surgery evaluation if that is where we think it is most appropriate. We will then decide on an operation together, and you will enter the surveillance program. All right, so with that, that's an overview of the program. I'd like to focus in on each of the clinics. And with that, I'd like Kathy to come up and talk more about the lymphedema treatment clinic and what she, Colleen, Stacy, and our future lymphedema therapists as well are going to do down there. Thanks.
Okay. So what we do in the lymphedema treatment clinic, not just mainly treatment. The first aspect I want to tell you about is our surveillance program. As Dr. Singhal mentioned, the preventative surgical procedures, we want to track these patients after they have that procedure. So we take measurements before they even go into the OR to make sure we get baseline measurements, some bioimpedance, volume measurements, various other objective measures, and then we track them after surgery. We see them 4 to 6 weeks after surgery, at 3 months, 6 months, 9 months for the first 2 years, every 3 months, and then every 6 months for the next 2 years, so that we can identify any start of lymphedema as early as possible and start treatment, and then track these patients. Hopefully they don't develop lymphedema. We do treatment of lymphedema, as he mentioned. You know, decongestive treatment, standard treatment. We follow patients pre- and post-operatively if they go on to have treatment, surgical treatment of their lymphedema. And then we also monitor people long-term. We definitely have a large cohort of patients who come in and they decide not to have surgery, but we want to follow their disease long-term to make sure it stays in good control. And then we have communication with the rest of the team to make sure we're all on board. And central to the team is the patient as the center, and make sure the rest of the team members are on board with what the plan is. So as I mentioned, our measurements, we do a lot of measurements, circumferential measurements. We calculate volume. We measure volume with the perometer. We take quality of life measures. We have patients, unfortunately, fill out a lot of paperwork. We really want to find out a lot about where they are in their life, their function, their quality of life, and then bioimpedance, so that we have all of those measures, objective and subjective, going forward. Complete decongestive treatment, which is going to be familiar to most of you, components of manual lymphatic drainage, compression, and exercise and education about skin care. But really the mainstay of treatment is going to be compression long-term. Once you go through that initial decongestive treatment long-term, we know that this is a lifelong disease and we want to keep it under good control, and really the mainstay of treatment is going to be compression. So it's kind of interesting when I talk to patients and ask them, one of the measures we use is how many hours in compression are you per day, per week. We track that as one of our metrics. It's interesting to me what the variation is. So we see out of the last 150 new patients that we saw over the past year, we see a little over 35% are wearing compression pretty much day and night, all the time. And that's what it requires to keep them in good control. And then we have a little bit more than 15% wearing it more than pretty much all day, waking hours. And then we have another 15% that are wearing compression really occasionally, maybe a few hours a day. And it surprised me that we have over 30% of our patients who don't wear any compression at all. So that's really where I dive into. So then I start asking more questions. Why? Let's figure out what's going on here. And for various reasons. I've had plenty of people who just say, I gave up. I can't take it anymore. I had to stop wearing it. It didn't seem to help. I can't stand it. It's too hot. I get a hot flash in the middle of the night and I have to take that thing, rip it off, and throw it on the floor in order to get back to sleep. It's itchy. It bothers my skin. I just can't take it. Various reasons. It might be that somebody says that the garments are too expensive. I can't keep replacing them because it's costing me too much out of pocket. So those are some of the reasons we can get around that by looking at variations on the garments. But then we also have some people who say, this is all I seem to need. And we do know, because lymphedema is not only progressive, but there also is a component of fat hypertrophy that takes over. So sometimes the garment doesn't do very much good because it's no longer just primarily edema, it's a lot of fat hypertrophy, and the compression doesn't seem to be as effective anymore. So if somebody can only uses their compression when they're exercising or for certain activities during the day and they still maintain good control, good for them. We'll work with them to make sure they stay in good control and monitor them. So one of the things, the next step then, is we look at how to maximize control of their compression. And you're going to be talking to some of the vendors as you go through the day today. They have some various products, and we have somebody else talking about compression a little bit later today. But one of the first things I would look at is how much pitting is there. Pitting is when we kind of press our thumb into the tissue in the lower extremity or in the upper extremity. Does it leave an indentation? And I'll frequently ask people, if you put your arms on the edge of a table and after you've been sitting there for a while and then you get up, do you notice a big dent? That's pitting. That means there's edema there that is going to be amenable to some kind of compression. So I get it in my head, we got to increase the compression if there's pitting. So that's the first question. And how much does the edema increase during the day? If it's increasing a lot during the day, it's not really under good control. The compression garment needs to be improved. So we may look at increasing the number of hours in compression, increasing the compression class, how many millimeters of pressure is used in the garment, we might have somebody replace the garments more often. If the lifespan is going to be a maximum of 6 months, maybe somebody only is using it 3 months before it starts to lose its ability to compress. So we may have to replace it more often. We might have to go for a custom or flat knit garment that is going to resist giving or resist stretching as much during the day. And we look at, is the pitting localized or is it throughout the whole limb? If the whole arm or whole leg has a lot of pitting, we have to look at a garment solution for the whole limb. If it's just localized in one area, we might want to play around with the measurements of the garment and take it in specific spots. We might want to add a second layer, another wrap on top of it. If somebody has pitting edema in the below the knee only, they might wear a garment that goes to the waist and then a knee high on top of that. So various layering techniques to really isolate, trying to make a solution that really works for what the patient's problem is. So it's really absolutely not one size fits all. There's many different techniques that we can use. And I would try to work with a fitter who knows about a range of products that we can do to make it more customized to every patient. And then supplement use of maybe a compression pump or kinesio tape or various other methods on top of wearing compression garments during the day and night to keep it under control. For patients who are undergoing surgical procedures, you had a little bit of an introduction to the two different types of procedures. One is the excisional or debulking, and the other is the physiological procedure. So we try to keep patients in, before they go into surgery, in the best control possible. Minimize their edema, and then we see them postoperatively and take them through the postoperative protocols, both for the debulking and the physiological procedures. And then long term. At a minimum, if somebody is in good control and they want to make sure their disease doesn't progress, we may follow them and take measurements once a year to make sure they stay in good control, and we'll give them their numbers. They track their own numbers and make sure they stay in good control. If the edema is stable, that's the best scenario. Over years, we don't want to see a lot of progression. If it's well managed, if it's not well managed, then we might have to adjust their compression garments. We might have to add more exercise or tweak their exercise program or their home self-management program somewhat to make sure it stays in good control. And if it is in good control, then we give feedback to the rest of the team. And if patients are going to go on then to have a surgical procedure, we give them the green light and say, okay, the edema is under control, it's well managed, they're ready to take the next step if they're a surgical candidate. And then if not, we're going to follow them long term to make sure they stay in good control.
Thanks, Kathy. And really, Kathy, Colleen, Stacy, I mean, they are the workhorse of the program. If you notice, all the arrows go to the lymphedema treatment clinic. They don't all go to lymphatic surgery or lymphatic medicine. So they have been incredible. With that, I'd like to turn over to the lymphatic medicine clinic and invite Dr. Carroll up to talk about his evaluation if you were to present to his clinic.
Thanks, Dhruv. So I'll kind of briefly go through what we think of in lymphatic medicine and what our role is. So quickly, we're going to just touch on secondary lymphedema, a little bit more information. As Dhruv noted, secondary lymphedema is really injury to the lymphatic vasculature. It accounts for the overwhelming majority of lymphedema, about 99%, and up to 1 in 1,000 individuals will have secondary lymphedema. So it's relatively common, although we don't learn much about it in medical school and many physicians aren't very well versed at it. It's pretty common, with the mean age being around 50s. It can happen for a variety of different reasons. Cancer related, as Dhruv mentioned, is most common through a variety of mechanisms, most commonly being surgical, though radiation also plays a large role along with direct effect of the cancer itself. It can be quite common, as Dr. Slavin mentioned, in the breast cancer realm, which is what we often think of and see, but it's quite common in a variety of other cancers as well. And it can occur at really any time after your cancer treatment. Some patients will come in and say, I had my surgery and it just never went down. Others will come, I've seen patients 20, 30 years after their initial insult. Usually it's after some other second hit, they get a bug bite, some other trauma, total knee replacement, something like that, and all of a sudden their lymphedema that was or their lymphatic function that was hanging on now gets tipped over and they have lymphedema and the cycle ensues. Breast cancer related, we could skip over most of this, but again, quite prevalent in a variety of different risk factors, how many lymph nodes you have removed, if you have radiation, body weight, if you have a postoperative infection or seroma. So to get a little bit more detail of what we do when you come and see us in our clinic, our primary role initially is to make sure you have lymphedema. As Dhruv mentioned, about 25% of patients that come into our clinic don't actually have lymphedema or have a significant component of something else that may be driving their symptoms. So first we break it down to, obviously, is it your arm or your leg that's bothering you? And is it one or is it both legs that are bothering you or both arms? And we won't go through these in details, but if it's one leg, it's almost always lymphatic or your veins that are the issue. One of the two train tracks is not working. We can help differentiate that either through various imaging, and exam is most important. And then if it's bilateral, we have to open up our eyes, and I go back to my general medicine training a little bit and say, okay, do you have heart failure possibly that's contributing? Do you have liver failure? Do you have kidney failure? Are your thyroid not working like it should be? And we can undergo a lot of blood tests if needed to evaluate that if it's not clear cut that it is lymphedema. If it's your arm, the differential is a little bit smaller. It certainly can be venous, although vein problems in the arm are relatively infrequent. But do you happen to have a pacemaker? Do you have a prior port for cancer treatment that could have caused some narrowing of the veins? And there's some exam findings that will make us think that maybe there's a vein issue and not just lymphedema. And we can do a variety of different imaging, either invasively or non-invasively, depending on our concern. So, like I said, we think, is it one or two limbs that are involved? We think, okay, what is this individual person's risk factors for having something other than lymphedema, or is it so obvious that it's clearly lymphedema, we don't necessarily have to go down this path? Like I said, physical exam is so key to what we do in clinic, and then we have adjunctive imaging. The same for upper extremity, as the exam is so key to differentiating. This isn't our data, this is from another center, but it just kind of corroborates what Dr. Singhal was saying. A lot of patients that come through a lymphedema, really should be called an edema clinic up front, don't have actually lymphedema. So that's why we have to keep our mind and our eyes wide when you walk in the door, that although maybe someone's told you for 20 years that you have lymphedema, maybe you don't actually have lymphedema. So I'll kind of leave it at that, unless you want me to run through this part, Dhruv. I'll let you take through it. Okay.
Just because I know what's coming next. Thanks, Brett. I will share a quick story. I remember still being on the corner of Brookline and Longwood when my phone rang 2 years ago, and it was Brett, and he told me that he took the job to come on faculty at BI, and I literally think I jumped up when I got that phone call, because having that level, first, he's awesome. For those of you who have met him, you know this, and just having this level of oversight from the medicine side of patients, making sure that by the time they get to my clinic, everything else has been thought about, is really comforting to me, and is really helpful on our Friday mornings, which I'll get to in a second, where we all look at each other in the eye, and if we recommend surgery or we don't recommend surgery, we are all in agreement. And that's really important when you're dealing with a disease where we're all still learning to some respects, right? Okay, so that's a really nice algorithm we put up. Well, that's kind of how we like things to work out, but as you probably know, nothing in life works out exactly like that. So what really happens is that is the algorithm, and then every Friday at 7 a.m., we all get up, come to the hospital early before our clinics, and we run a multidisciplinary conference. We are all there. We are discussing any new patient that came through the clinic, and a critical part of that is reviewing imaging. And you'll see this gentleman right over here. Leo, come on up. That's Dr. Tsai. I'm trying to avoid the cameras, but he really is the lead on our lymphatic imaging. He's come up with some very unique protocols for lymphedema patients. He's been recognized for it and received grants on this. Leo, come on up and talk about some lymphatic imaging for us.
Thank you very much for that introduction. So a little bit about ourselves. We are a radiology department here, consists of 65 clinical faculty and 40 residents. We run almost close to 200,000 studies a year now, just at the BI alone. And so everything that you guys think of in terms of radiology, from x-rays to mammograms to MRIs, nuclear medicine, that all falls under our purview. And as Dhruv mentioned, one of these multidisciplinary conferences is in lymphatics, and there are another 15 of them that we're also intimately involved with. This is our team as it is today. it started with me and Kevin Donahoe, who's sort of in the middle row there. And Dhruv actually was he was my senior resident when I was an intern. That's when I first met him, and at the Brigham. And then I came over here to do my training, and then we basically, and then he resurfaced a number of years later and just said, hey, by the way, we should actually do this lymphedema stuff. So, and that was my introduction to lymphedema. Previous to that, I had no exposure to that whatsoever. We've quickly built a pretty strong imaging team here. It started with just two of us, and then Marty Smith on the upper left corner here is also a body imager. He was one of my mentors here when I was training, and a real guru in MRI protocols. And then the two bottom individuals, they're part of the interventional radiology team, and I'll sort of explain more about some of the things that we do. Next year, we actually have a new faculty member, Dr. Kim, the upper right corner, who's actually joining our faculty as a breast imager, and she has done a lot of research in lymphedema. Will continue to do that work here as well. I really would like to say that that is really just a small number in terms of our entire team. What you often see when you get your imaging done is you often see our technologists. They're the ones that put you in the scanner, actually take the radiographs. They're responsible for getting the actual images that we're able to interpret. They're really our front line. And so, when I talk about radiologists, we're really only at the very tip. They're really sort of doing the brunt of the work and sort of making sure that you're comfortable, making sure that your scheduling is fit. And so I really just wanted to give a shout out to them for basically making our team function. So a little bit about our lymphedema protocols. I think a lot of, one of the things that I would like to sort of put across to you all is that sort of imaging protocols and imaging examinations are not all created equal. And so one of the great things about being here and sort of working with Dhruv is that a lot of the best imaging that you can get, there's 15, 20 different protocols that you can run on MRI just to look at the arm. But we actually created a specific lymphedema protocol, and that's possible because I know by talking to Dhruv and talking to Brett what exactly the information that they need. And I'm able to go back and talk to the technologists and my colleagues about how best to protocol these types of studies. If you look at the images below, these are all images required for one examination for a patient, specifically looking at their kidneys. And so I'm primarily an abdominal radiologist, and I specialize in MRI. Just in the abdomen alone in MRI, we have 85 sequences, different types of protocols just to look at the abdomen. It depends on the body part, what organ you're looking at, what disease processes. And lymphedema is a separate disease process, and it should be sort of protocoled as such. So some pictures in case you guys have never seen sort of some of the things that go on after you have your examination. This is an example of a lymphoscintigraphy examination where they inject the tracers between the webs in your toes. I'm sure many of you have experienced this, but what goes on afterwards is we take multiple images and we look up at our screen to see where those tracers go. And so this is an example of one side. This was just done 2 weeks ago. One normal side where the tracer goes up, and these are your lymph nodes in your groin going up the leg. But on the disease side, where that's affected by lymphedema, the tracer doesn't go up at the same amount of time. It gets stuck here. And there's this sort of pooling here, which you call dermal backflow. And that's one of the things that we look at. We can also add sort of cross-sectional imaging, CT examinations, in addition to look for where those radio tracers go. This is another patient where we don't see any of that tracer uptake on the affected side, but there's uptake here in one of the normal lymph nodes in your axilla. Okay, so those are some of the examples of what we can do with nuclear medicine, and that's what Dr. Donahoe is in charge of. So what I primarily do is MRI, and these are some images of a patient with lower extremity lymphedema. So this is the patient's actually the left leg and the right leg. We reversed those left and right when we were interpreting images. But one of the things that Dhruv would really like us to tell them is basically how much of this swelling occurs because of the fluid and how much occurs because of other things. And just as important is basically where is the fluid distributed? Basically, where are the trains, right? And that's something that you can't necessarily tell looking at sort of the physical examination. And so the top row here is an example. So this is from the same patient from the same examination, but by sort of tweaking the protocol on the machine can tell us basically this image here, anything that's bright is actually representative of fluid and edema. And you can see there's a lot of this bright stuff, and the soft tissues here are thickened. This is a patient that has a lot of edema. But in addition to that, I can also tell the machine with our sequences, can you actually give us an output that just tells us where the fat is also located? And this is something I think that'll come up a little bit later. With chronic lymphedema, there's also an increase in the amount of fat in that same limb. And you can also see in this image down here, everything that's bright in these images over here are fat. And so we've constructed this image so that you can actually see in the same patient, even though there's a lot of fluid, there's also a lot more fat in this leg than on the other leg. So it really helps sort of guide what types of therapy should occur next. Lastly, our interventional team, Dr. Amin and Dr. Weinstein, they are able to take patients and provide sort of additional images under fluoroscopy where they inject contrast agents directly into the lymph nodes. And you can actually see where the lymphatics are draining sort of in the mid and upper body in areas where MRI is sort of a little bit more challenged. And so this is an example of a patient that they saw where there's clearly sort of dilated lymphatic channels, and these don't look totally normal either. And in situations like this, if the option arises, they see an area of stricture, they can actually go in and they can balloon it. So a lot of, we call this angioplasty. Most of you guys think of that in terms of coronary vessels, like to prevent heart attacks, you blow up those arteries to clear them again. You can actually do this with lymphatics as well. You can actually even stent them so that in patients who have central blockages, you can open them back up again. And in this patient, actually, the outcomes are really, really great. And the last slide I have is basically just a quick info page for those of you who want more information about radiology and what radiologists do. I think this is sponsored by our American College of Radiologists, and I strongly urge you to look at this just so you get a better sense for some of the things that sort of, if you have any sort of basic questions about what imaging is like, regardless of the study that you're undergoing. It's all categorized in different segments. And I'll stop there. All right, great.
Thanks, Leo.
Yep.
All right, we have about 7 minutes left, and I promise to end on time. It's really important to understand all lymphedema is not the same. It might look the same from the outside, but it's really the key imaging that Leo and his team are able to provide us that really differentiates if a patient's fluid dominant or fat dominant. And Leo, I forgot, you were my junior resident. I guess I'm still torturing you. All right, so finally we're going to end up with the lymphatic surgery evaluation. And so I'd like to talk more about if you make it to the lymphatic surgery clinic, what we actually do to work you up. And this is if you have chronic lymphedema. You've passed Dr. Carroll, Ms. Shillue and her team, and everyone agrees, okay, this is lymphedema and it may be amenable to surgery. So we will do, this is usually now already done by Dr. Carroll. We'll do a bunch of imaging. Kathy, her team will already have done the measurements. And really, I'm doing a clinical exam, again, assessing fluid versus fat on that exam. And combined with the imaging, we make a decision. Is this fluid predominant or fat predominant? If it's fluid predominant, we're more likely to offer you one of those bypass transplant procedures, the physiologic procedures, versus if you're fat dominant, we're more likely to offer you a debulking procedure. And give me a few minutes, and I think all of these procedures will make perfect sense. So looking here, first at lymph node transplant, this is how we used to do lymph node transplant. When I first started in 2014 doing this, I did it the way I was trained to do it in Taiwan. I would go take lymph nodes from the groin or from the base of the neck and transfer them into the affected extremity. And we are on version like 7.4 now, and I'll get into what we do today. But I like to show these pictures mainly to show, A, where we put them. So we actually don't put them where the lymph nodes were removed. We like to put them further down the extremity. And that has to do with gravity and things. And that's how the physiology of the lymph node, we believe, actually works. And the other reason I like to put up this slide is I want to show you this. So this is a concept sometimes when I talk to patients, it's a little hard to comprehend. I'm like, imagine I'm going to do a procedure on you where you're going to say you don't look better, but you feel better. And this is a patient I remember I did a lower extremity lymph node transplant on, and she had a gynonc procedure, which led to this radiation to the pelvis. And this was down in Florida before I left. And I remember I usually go back and make these smaller and leave the lymph nodes behind. We need to make it bigger in the beginning just to keep the lymph nodes alive. And she told me not to touch her. And so this is a woman in her 50s living in Florida. And she was okay living like this because of how much this lymph node transplant had helped her in terms of her symptoms and her ability to live her life. And she'd rather live with that than risk it potentially getting damaged if I debulked it and left the area. So I thought that was a very telling story for me as well as a clinician. But I said we're on version 7.4. So what we do today is we actually open up the abdomen, we go into the abdomen, and usually what we do is we take lymph nodes off right around the stomach. And we like to do that because by doing that, you don't really risk lymphedema in the arm or leg, wherever you are removing the lymph nodes for the transplant. So that's the main driving force for why we're now going into the abdomen. So we will actually take out this tissue called the omentum. That's what it looks like. And this is, for example, in a patient who has upper extremity lymphedema, we will take one of the two arteries going to the hand called the radial artery, and we will inset those lymph nodes into the radial artery like this. And so the blood flow to the hand via that artery stays the same, but it now traverses a bunch of lymph nodes that sit in that fat. And by doing so, we have transplanted lymph nodes into the affected arm. And if you look here, this is what a typical pocket looks like when it comes out of the abdomen. It's 26 grams, so it's very small. And we use an ultrasound intraoperatively. Actually, Leo comes in and does that for us. And it really, I can walk out of the OR when we're done, walk up to the patient and say, today we transferred 6 lymph nodes into your arm or leg, whatever the case may be. So we're really trying to bring more objectivity to what we do. This is just a look at what it looks like right before we put it in. And this is how a patient may look at early follow-up, where now we're able to bury the lymph nodes under the skin. And actually what I do is I'll debulk some of the other tissues. So if I'm putting in 26 grams, I try to take out 26 grams. So it's a zero-sum game when we are done in the OR. So these physiologic procedures, I just want to give you the big picture concepts. They are really good at decreasing the need for therapy, improving symptoms, and decreasing risk of infections. I will say though, volume improvement is modest. Okay, so you will look at your arm or leg and say, I feel better, but it doesn't look better. So that brings us to the other approach for lymphedema, which is a debulking procedure. I'm just going to ask a quick question. The timer reset. Am I okay? Perfect. Thank you. So the other procedure is a debulking procedure, and that is, let's give you a case example. This is a 43-year-old gentleman who is an avid golfer, had a pancreatic transplant, and then developed lymphedema of his left lower extremity. He wasn't playing golf anymore, and he came to see us. He had been living with this for 4 years at the time. So this is a slide from Dr. Borson. So the debulking procedure is one that our team recognized we needed to go learn because we were doing these other procedures, the physiologic procedures, and patients were feeling better, but they weren't happy necessarily with their appearance. And so actually Kathy and I got on a plane and spent Thanksgiving week a couple of years ago out in Malmo, Sweden with Dr. Borson. He developed this procedure. And what he's shown is when a patient has lymphedema, certain patients on the lymphedema side will develop fat hypertrophy. They'll develop fat out of proportion to the unaffected side. And this is just an example from a cadaver that they took and sliced to demonstrate this, where the patient had lymphedema on the side where you see more fat. And so what he came up with is this very aggressive technique where you do power-assisted liposuction. You literally go in and you're suctioning liters out of an arm or a leg in one go. You need a specialized equipment to do this because you have to move quickly for bleeding purposes. And this is like a typical canister that we will take out in our first run. And we'll take 6 to 7 liters out in a given leg, for example. And this is the device we use. It's very aggressive. But this is him at 1 year, right? So you can already hear the wows, right? So this is a 1-year follow-up. I've seen 30-year follow-up, and this maintains itself. Okay? So with excisional procedures, you get the wows, okay? You get the significant volume change, symptom improvement, decreased risk of infection. However, you do require compression 24 hours a day, 7 days a week. Yes, when you sleep, you keep it on in order to maintain it. All right, so that is the big plus minuses of the two main approaches. And I want to quickly touch upon, it looks like I have 7 minutes left, prevention. So everything we just talked about was chronic lymphedema, approaches to it, management, imaging, measurements. Switching gears a little bit, I want to talk about prevention. We talked earlier about how lymphedema is a progressive disease. And so the question is, why not? We know it's caused in the operating room. Why not try to fix it in the operating room before it develops? And so here, I'm going to focus in on breast cancer in particular, just because about 46% of the patients that come to our center have breast cancer or have been treated for breast cancer. And so what our group did was we went back and we wanted to define what's the baseline risk of getting lymphedema if you have breast cancer, and specifically if you have that axillary node dissection, which Dr. Slavin talked about earlier, where you need your lymph nodes removed. Everything I'm going to talk about can be translated to other parts of the body. And what we basically found is if you have a lymph node dissection, your risk of getting lymphedema is 14%. This is looking at 1,500 patients in the literature. However, if you add on radiation, a specific kind of radiation, but radiation, your risk goes up to 33%. I will tell you the majority of patients that end up with this end up with this. So your real risk is right around that 26 to 33%. And so these brilliant Italian surgeons in 2009 said, time out. Why don't we, at the time of removal of these lymph nodes, find the lymphatic channels and do a bypass and connect them to a vein in the armpit? And they did this, and what they were able to show with 4-year follow-up is their rate of lymphedema came down to 4%. So I told you, I think we have the largest experience in the US right now on this. We queried our database doing this since 2016. We only looked at patients who had successful completion of the procedure, and the most important thing was, in order for this to be deemed scientifically sound within our own community, we only included patients that had a minimum of 6-month follow-up, okay? And then we looked at all their characteristics. And this is all I want to show you, is we ended up looking at 32 patients, because that's the one we had all the preoperative, postoperative data, appropriate follow-up. So if you're out there, please follow up with us. We know most of you aren't following up because you're doing well, but we need that data to prove a point, which is actually going to be very important in the future for other patients. And here we had, as you can see, 88% of our patients got radiation therapy. Specifically, 93% of those were getting the special kind regional lymph node radiation. So again, your baseline risk should be in that 26% range. And here, I'll just get to the punchline. At 11.4 months of follow-up, we only have 1 patient that's progressed to lymphedema, giving us a rate of 3%. I think that number's too low. I think it's going to climb a little bit with more follow-up. I don't think we're going to end up at the 26%. So while we're early on this, I do think this is a really important potential maneuver moving forward. This is just looking at all 32 patients, all their visits. A clear circle means they were evaluated by Kathy and her team with all the measures, and they did not have lymphedema. Black implies they'd hit the definition of lymphedema, and as you can see, only one patient progressed. And this is in 32.5 patient years. Okay, 3 minutes left. This is maybe the slide that's really going to catch your attention. So before I leave talking about the clinical program, I want to show you this. So all lymphatic surgery was deemed experimental, is deemed experimental by just about every insurance company that I know of in the United States, in every state. However, our team has been working directly with the biggest insurer in Massachusetts, Blue Cross Blue Shield. We wrote the policy with them. We had about 30 meetings. And this is the first policy in the US. It went live a couple of months ago. You can Google it. It's policy 037. And it provides coverage for these procedures, not prevention, but for chronic lymphedema, it provides coverage for these procedures moving forward, assuming the correct criteria are met. So I think this is a big win. Again, this comes from a lot of advocacy. This comes from a lot of advocacy. This comes from all of you coming here today. This comes from working with people like Mr. Rapisi, and LE&RN will be integrated into these policies. With that, I have 2 minutes left, so I just wanted to show you some of the work we're doing on the research side. We're not just here about seeing patients, we're here about advancing the field. So your family members, your kids, their kids will have something hopefully even better for them if they were to develop lymphedema. And so we do have a research program. Again, it comes back to the team. We have a slew of research fellows that are working with us. The hospital supports us on the regulatory standpoint with statisticians and people that help us make sure our research protocols are, all the T's are crossed, I's are dotted. We collaborate heavily with Dr. Padera, who will be speaking later over at MGH, Dr. Chatterjee, who helps us look at cost of what we're doing and making sure it's effective for the healthcare system, and Dr. Choi, who's an imaging expert over at MGH as well. I'll just briefly mention, we do work on pigs. Pigs have the closest lymphatic system to the humans, actually, and we have been able to cannulate lymphatics on pigs, inject different dyes in them, and we actually have done very sophisticated studies looking at lymphatic clearance in real time on pigs, and we've published our work, and we actually have 2 grants currently working on this, so we are funded and looking at that. We also can image lymphatics in the clinic. This is ICG lymphography, this is near-infrared imaging, this is just a video showing what this looks like in an arm, where this is a very diseased portion of an arm, which is what we call a diffuse stardust pattern. But then you can get to other portions of the arm that are actually very healthy, and you see a very nice lymphatic channel there. But one of the problems is nobody knows how to interpret these. So we've worked on translating some work other PhDs have done into something that's clinically sound. In 3 minutes, we can image one part of one area, take one region of interest here, shown right here, and actually kind of get an EKG out of it. And we actually define normal contraction rates, and we're looking at that in various places. We have a randomized controlled trial currently for lymphedema. Again, Dr. Tsai has 2 grants looking at lymphedema imaging specifically. And in conclusion, I will just thank you again for coming. It's an honor for all of us to be here and to spend the day with you. This is a picture from our symposium last year, all the faculty with Ms. Bates, who was our keynote speaker last year. And again, thank you, and you're gonna have a wonderful day, and I'm gonna pass it off to Kathy and Lisa.